NTM MAC lung disease. I'm Patrick Flume. I'm at the Medical University of South Carolina, where I direct the Adult Cystic Fibrosis Center and have programs dedicated to bronchiectasis and NTM. And I'm joined today, it's my pleasure to introduce you to Dr. Addrizzo-Harris and Dr. Kevin Winthrop. So could I ask you all to both introduce yourselves? Doreen?
Sure. Hello, everyone. I'm Doreen Addrizzo-Harris. I am a professor of medicine here at NYU Langone Health in New York City, and I'm the director of our bronchiectasis and NTM clinical and translational program.
Hi, guys. I'm Kevin Winthrop. I'm a professor of infectious diseases and epidemiology in the School of Medicine and School of Public Health, and director of our Center for Infectious Disease Studies at School of Public Health at Oregon Health Science University in Portland, Oregon. It's a pleasure to be here.
So welcome to you both. And for the audience, let me let you know that feel free to send us questions or comments throughout the broadcast, and we'll do our best to see those. You can also just tell us hello and share where you're from. I'd also like to mention that this program is supported by an unrestricted educational grant from INSMED. So I'm going to start with you, Kevin. The 2020 NTM guidelines recommend treatment initiation rather than watchful waiting in certain diagnosed patients. So how do you decide in your own practice whether to start therapy or when to wait?
Well, I have a quarter here, Patrick. Let's do that. Heads, treat, tails, we wait. I mean, sometimes I'm not joking. I mean, sometimes that's kind of where you are as a consultant. You're not quite sure. I always tell patients that the two things that really push me to offer therapy are if they don't feel good, right? They have symptoms and you feel like you can make them better. It's a quality of life issue. Or if you're looking at their scans and you see evidence of disease progression or, moderate or severe disease, you want to slow that down or, help arrest it as much as you can. So, I mean, those to me are the two triggers. And that's how I kind of talk about it with patients anyway. There's other risk factors and whatnot, and I'll let Doreen cover those, but those are kind of my two big things in terms of what are the objectives. And if we're going to do this is what we hope to accomplish.
All right. So let me ask you, Doreen, then, what patient factors for those with MAC lung disease, what makes you more aggressive in terms of your treating, or what makes you more conservative?
So again, what Kevin just said, those are probably the two most important things: quality of life and how are we going to impact symptoms. So someone who's asymptomatic, we will be more hesitant to start on treatment unless, as he said, they have a progressive or very a CAT scan that has severe disease, such as cavitary disease. But we do know there are certain risk factors that put people at a risk of higher progression rates. And some of those things would include patients who are immunocompromised or who are on immunosuppressant agents for other diseases, patients who are older in age, and actually male gender has a poor prognosis for progression. Patients with other comorbidities like underlying COPD or interstitial lung disease will probably be more likely to progress. And then patients who are malnourished, we know that that's also a high risk. Low BMI and patients who are also have anemia and hypoalbuminemia are at increased risk. And then I think the other big piece is we're talking about MAC lung disease here. So for that, someone who may be smear positive and have a heavier burden of the bacilli may weigh you to push to treatment versus somebody whose culture may be smear negative and takes 6 or 7 weeks to grow. So, the burden of the bacilli is less in that patient. So putting all of those things together with discussion with your patient, because the quality of life that they're going to have on meds, you don't want it to be worse than the quality of life they had before. So weighing those two risks, all of those risk factors is quite important.
Yeah, I just add to that I think that smear is really important. I mean, there are people where they have pretty few symptoms, and I otherwise may not be offering therapy, but they're smear positive, and I know they have a huge bacillary burden. And there's good data from several studies suggesting those people are much more likely to progress. So if you don't start them therapy, definitely keep them close and have a low threshold.
Well, yeah, that's the other big point here is a lot of other patients, the patients that we see, were told at some point prior in their life that, okay, you don't need treatment, you're good, goodbye, see you whenever. So the important thing is to continue to monitor anyone that you decide you're not going to treat with, CAT scans and clinical exam. And so make sure that they're not lost to follow-up.
Well, let me throw a curveball at you. So what about those patients that don't produce any sputum? So you take them to bronchoscopy and the smear is positive in those patients. Where do you rank them in your bacillary burden?
I don't know that you can compare the BAL to sputum. So I don't really use the smear as a decision maker with bronch. And there's also the case of people who are not producing sputum. They tend to be less sick than those producing sputum, not just from a symptom standpoint, but they probably have less actual infection or less disease. So, obviously the CT scan is really important, despite the fact that we never really formally measure it. We don't use it in our studies and whatnot. I mean, I think clinically we all use it quite a bit, and it helps us, at least categorize someone to mild, moderate, or severe, or, cavitary, non-cavitary. And those are the kinds of things I think that push you as a clinician toward offering antibiotic therapy.
All right, well, let me take that one step further then. We've decided to treat the patient. I'm assuming we're using guideline-based therapy. So what tests, and I'll put this to you, Kevin, what tests or assessments do you use to tell if the treatment is working?
Well, we don't use guideline-based therapy, Patrick. No, I'm just kidding. No, I'm just kidding. We do, but no one else seems to. At least if you believe some of our studies. But yeah, I mean, obviously the recommended regimen, if we're talking MAC, you're looking at azithromycin, ethambutol, probably with rifampin, although we just did this big study comparing azithromycin, ethambutol versus all three drugs. And I don't know the results yet, so we'll know in a month or two. There may be some subset of people where it's just fine to use two drugs. How to tell whether it's working. I mean, obviously if they produce sputum, that micro endpoint of culture conversion, I think, is really important. It's been shown to at least, predict future relapse or not. People that convert their sputum are less likely to have this come back or get it again. So, we follow micro and we follow CT scan. I mean, I don't know about you guys. I usually scan someone 4 to 6 months in just to make sure things are going right. It depends a little bit what their underlying disease stage is, or, how much disease they have. But, and then I certainly always do a scan at the end of therapy to kind of capture a picture of what they look like. So, I mean, radiology, micro, and then we have this new blood test. We're doing a study with you guys, or helping with it. And, we're looking at cell-free DNA as a biomarker for treatment response. And I think that's going to pan out, but I don't have that finalized yet.
All right. And Doreen, it's not uncommon for our patients. We put them on drug. They can't tolerate some of the drugs that they take. So when a patient can't tolerate one of these first-line agents, what adjunctive things do you do to try to mitigate that, or what are your alternatives in terms of changing that regimen?
So we could have a session just on that topic alone. But typically, even if someone comes to us and they have been intolerant with the prior trial, we'll probably try again, depending on what the side effect was. By a stepwise fashion of introducing drugs one at a time. So we'll start usually with ethambutol and give it a week and see how the patient does, so that we can detect if a rash or if GI side effects happen, which drug it's from. And so we do a gradual introduction of the meds till we get them on all three. If they do have significant side effects, and some of the side effects are side effects where you're not going to want to continue the drug again. So if a patient does have optic neuritis from ethambutol, or has significant hearing loss or tinnitus from a macrolide, that's problematic. And then we're going to have to, rethink the regimen. If they have, some bone marrow suppression, thrombocytopenia from rifampin, there are things you can do with each one of those. So, if we can't use rifampin, once in a while we'll try rifabutin. Sometimes it doesn't have the same GI side effects, or some of the bone marrow suppression. And again, I'd like to say that, when you use 3 times a week intermittent therapy, which was what we use for most of our nodular patients, the side effect profile is very, very low for most patients. I know patients are very fearful of this. So we can try rifabutin, or as Kevin said, maybe 2 drugs are sufficient, and we'll have that answer. Or substitute a medication like clofazimine, which many centers have access to as the 3rd drug if you need that drug. If you lose a macrolide, we know that the treatment effect is going to be much less. So you could try clarithromycin if you have problems with azithromycin. Often you'll get the same side effect profile. So then thinking about adding additional therapies, depending on how severe the patient is, such as amikacin, either in the intravenous form or aerosolized, nebulized, if you can get it. If you can get it in the liposomal form, certain insurances won't pay upfront for that. Or we often will go to the parenteral form of amikacin and use that inhaled if we need an additional drug. So there are some options, but again, it's patience, it's trying, it's, stopping and restarting. It's really important to be sure which side effect is from which drug.
So you mentioned the TIW. So Kevin, I might come to you with this one. So obviously going from a daily regimen to a 3 times a day, or both of you have mentioned the 2-drug regimen for MAC that's been tested now. These are dose reductions, which seems a little counterintuitive. Usually things are always an add-on. So are there any other times where you back down on your dose if patients are not tolerating it?
I think the nice thing is there's data to support doing all the things that, Doreen just said, as well as I would say I do things slightly different, but the data says it's all fine, whether you're 3 times a week or daily. My experience is that people tend to like daily dosing better for a couple reasons. You have a smaller dose of the macrolide, which I think is better tolerated, and people forget, and that way if they forget once or twice a week, they're still getting it in 5 days a week, and they have a hard time. On Wednesday you forget, and then all of a sudden it's Thursday, and it kind of messes you up, and then you don't really know how to keep going 3 times a week. Next thing you know, you're on a Thursday, Tuesday, Saturday schedule. It's confusing, especially for older people sometimes. So I don't know, I'm kind of an everyday guy, and I think people like the lower doses better. Whether the lower dose daily, ethambutol and optic neuritis, that's a real issue, right? It's rare, but it's not that rare. It's 1 in 300 or 400 people. So I get a couple cases every year, it seems like. I don't know that it's any more common with, higher dose TIW or lower dose daily. But the bottom line is I dose that very appropriately, like right on the 15 mg per kg. I do not venture higher. And a lot of people will be loosey-goosey with it. They'll go 20 mg per kg, things like that. And it's definitely a dose-related issue. So those are my feelings on dose. And then RIF, and sometimes Doreen said rifabutin, and that's true. And sometimes that's because of drug-drug interactions too. That's all I was going to add there. Sometimes you need to
forget about
like that, or you can't even use any of them. And everybody seems to be on Eliquis now anyway, so you can't use any rifampicin. So you're, then you're thinking either a 2-drug regimen or adding, inhaled Arikayce or amikacin, or going to clofaz. Those are kind of your options.
Yeah,
All
so
right.
really the severity of the patient, Patrick, is really what's going to make us, to how aggressive we have to be and how many drugs we need to have them on.
All right. Well, so we talked a little bit about treatment success. Kevin talked about how he looks at it and when he does testing and such. Well, let's just flip that coin and talk about treatment failure. So I'm not talking about intolerance of medications, but how do you decide when you need to pivot or add on to do something? So assuming your patient's adherent to the regimen you put them on, why don't they succeed? Why are they not achieving it? And how do you define treatment failure?
So that's a very good question. We consider patients to have treatment failure or have recalcitrant disease if they're still culture positive by 6 months and they haven't converted on whatever regimen we thought was appropriate for the severity of disease, right? So, if you're starting someone on, and Kevin sounds like he likes the daily regimen, but we really do make a decision who gets 3 times a week or daily. And I would say, if you're starting somebody with cavitary disease on 3 times a week therapy, that's inferior therapy. So, they're not failing. You just weren't giving them adequate therapy up front, right? So the recommendation there is clearly daily therapy, often with intravenous amikacin. But if you're giving the patient appropriate therapy, what do we think about when they're still positive after 6 months of treatment? First, we want to make sure that they're not having significant aspiration, and we know a number of these patients are not only not curing their first MAC, but they may be reinfecting themselves. So we'll often do a significant workup, a GI workup, to make sure patients aren't having asymptomatic reflux, particularly when they're in that recalcitrant group. And sometimes, depending on the patient, we will also check drug levels to make sure they're absorbing. If you've got a patient who's very malnourished, who also has IBD, those would be patients who would be increased risks of having malabsorption, and we'll do drug levels then, maybe even sooner than 6 months in that group. And then, but then at that point, we have to decide, I'm assuming they're doing better clinically, because if by 3 months they're not, we may escalate our therapy. We may go from 3 times a week to daily. And then, at 6 months, we would consider adding a 4th drug. If they're already on daily, adding inhaled liposomal amikacin at that point. If we can get that approved, sometimes adding clofazimine as the 4th drug, if there's a reason not to add, if they have a contraindication of having inhaled liposomal. So there are a number of things that you would want to consider doing if they're not responding.
Yeah, I just add to that. I think the drug levels, I know we don't recommend them routinely in the guidelines, but we do mention using them in instances like Doreen said, like where you don't think your patient's responding. And that is definitely what I do. Someone's symptoms don't get better or their sputum fails to convert, I definitely check to make sure they're absorbing. And I would say that it's not uncommon that those kind of people aren't, and they'll come back with an azithromycin level of 0.04 or something. And I'll raise their doses and then they will convert. I mean, this is anecdotal. I should look at this formally, but it happened to 2 people this week, yesterday in clinic. I mean, that was their story. So I think it is important to think about that always in the back of your head. Is this person responding? If not, look for reasons why.
So let me ask you both then, if a person is symptomatically improved, they stop coughing, they stop producing sputum, they feel better, but they remain culture positive, is that a treatment success or is that a treatment failure?
It's a 50% success.
No,
I mean, I don't know. I mean, we could argue about what's more important, the PRO or the micro, right? This is what we do with FDA in our trials, but obviously they're both important. And, but probably if I had to say, I would say that the PRO or the patient reported outcome, the quality of life, the symptoms, I think that's the most important. And I mean, I have a lot of people that feel great and they're still culture positive, and I may treat them for a year or whatever. And I still stop because they feel great. I'm going to watch them closely, but, that's more important than their culture, I think.
I agree, and I think if we add in the CAT scan, if their CAT scan has stabilized or improved, and they're feeling clinically better, but you still have positive cultures, I say we'll stop and then watch them closely at that point. So I do think that is a positive response.
Yeah,
Yeah,
so
right. We've achieved, 2/3 of what we wanted to do, and really the two most important things, like Kevin started with symptoms and CAT scan. And so if you can do that, I think that's, chalk it up in the positive category.
Yeah.
But keep in mind,
Patrick, what do you do? I mean, you don't get to just sit there and ask all the questions. You got to tell us what you do.
It turns out it said moderator at the beginning. So
it did.
Now I do not use the term treatment failure if they clearly are symptomatically improved.
Right.
And I do still wonder when we have positive cultures that remain. Doreen mentioned the possibility that they keep reinfecting themselves. Yeah. And another thing that is mysterious to me is sometimes we repeat susceptibilities on those bugs, and the bugs remain susceptible to the drugs that we're using. And that just boggles the mind that you would expect that you should either eradicate or select out more resistant versions, and that oftentimes doesn't happen. But nonetheless, we have adopted that term refractory disease, which really is dependent upon remaining culture positive. And just in light of the original liposomal amikacin study, how do you differentiate? Because we've chosen this time of 6 months to sort of make that distinction. That is it true, we'll call it failure, refractory disease, or just a delayed response? Are some of those going to achieve culture conversion at 8 months, for example, or 9 months?
Well, I mean, the data from the Insmed trial, like, 9% of people still converted in the placebo group in the next 6 months. So at the end of 12 months, you captured another 10%, people. So, I mean, clearly some people just have a delayed response. Some people aren't absorbing, and you can correct that at some point. And then other people, I mean, I think of it as microbiologically refractory disease or culture refractory disease. I mean, I'm pretty sure that if you counted the bugs, you may have knocked the population down 80%. There's culture positive. You made progress, and you can see it on the CT scan, you can see it in symptoms. And I think a lot of those people that you were talking about before, that even though they're still culture positive, they still have had quite a bit of gain from a micro standpoint. We just don't measure it with our binary culture positive, yes or no.
Great. Well, Doreen, let me throw another one at you that we've kind of said, I've heard 4 months, 6 months, at which point we check the CT and so forth. We do the same thing. Is that waiting too long? Should we be making a judgment on success of treatment earlier than at 6 months? Is there some risk of waiting until then before you make a change and pivot in their therapy?
So in most patients, I don't think so. I don't think it's waiting too long, and I don't think we see any detriment to the patient. Would I like to have a more effective drug up front that converts them in a month? And we saw that in the ARIKAYCE trial. We saw a lot of conversions that were happening right away. And so, again, we'll have an answer soon from another trial if ARIKAYCE should be used up front with azithro and ethambutol. And, I'd really like to see that. I'd like to, have a trial where by 3 months we can say, everybody should be converted by that point. I think where we have to worry is in patients that have severe, more severe disease, like cavitary disease, and sometimes waiting a little bit too long. If you have somewhat localized disease, it can spill elsewhere, and then you've got multi-lobar disease, then it's no longer, the best case for surgical resection, if that needs to be part of the plan. So that's where I worry most is when there's severe, localized, potentially cavitary disease that could be treated with antibiotics and surgery, and the surgical part is delayed.
Yeah, I agree, Doreen. I mean, those are the patients I scan sooner. I scan them 2-3 months after therapy to make sure the cavity is going the right direction. Because sometimes, despite therapy, as you know, the cavity goes the wrong way, and you got to got to get that out of there. So
So
that's pretty much the only time I scan earlier. But I mean, you know, if someone's failing to improve clinically after 3 months, I mean, you know, we've done those studies, right? I mean, the bulk of your clinical benefit you see in the first 3 months, and then you kind of plateau between 3 months and 6. You have a little more improvement, and after 6 months, you don't change a whole lot. So, I mean, you should be seeing something by 3 months, and if you're not, and particularly if they have severe disease, as you said, I think, you know, repeating scans not a bad idea, or checking their levels, you know.
And we didn't mention sensitivity testing. I don't think we did, but making sure, or maybe you did, Patrick, right? Sending that isolate to be sure that it is, you know, what your sensitivities are up front,
Right.
and making sure it's both azithromycin sensitive in the beginning, and that you're not dealing with macrolide resistant disease. And again, just talking to the patient too about their environment, because there are some patients who are, you know, in hot tubs and gardening every day, and they're probably just getting reinfected with a lot of different MAC cousins. And so I think that that's a very important discussion to have early on with them.
And the other reason we get frequent cultures is because sometimes they're symptomatic and it's not the MAC anymore, it's their Pseudomonas or other agent that we want to focus on.
Yep.
But before we run out of time, I do want to talk about, you know, the pipeline. So talk about emerging strategies. And so we talked a little bit about the 2v3, 2-drug regimen. But just maybe first I'll go to you, Kevin. What are you excited to see?
Sure. Well, you know, Doreen already mentioned the ARISE trial, and the inclusion of ARIKAYCE frontline to see how that affects things. And as you guys know, we've talked about, the preliminary data looks really encouraging, right? It looks like people are converting sooner, like Doreen said. And so that I'm hopeful is going to be an option for people who particularly have more severe disease. I think that might be something we want to pursue. You know, in terms of new therapeutics, you guys know we're all doing these studies, but inhaled clofazimine is being looked at for refractory MAC disease right now. I think it's a great idea. We'll find out. Unfortunately, a couple drugs failed last year. You know, Spiro had a drug that was the old SPR7-720. I don't know what the real name was, but it probably worked, but it caused too much liver toxicity, and so that was stopped. AN2 has a drug, epetraborole, which I think does work and should work and looks really encouraging, but unfortunately that was a refractory MAC trial, and really the wrong kinds of people got enrolled. There were people who were never going to get better no matter what you gave them. So, you know, whether that's dead or not, I don't know, but I think that's a compound that, you know, deserves further evaluation, and I'm hoping we'll get the chance to do that. You know, there's various formulations of nitric oxide out there people are playing with. Nothing in phase 2 yet that I know about. And then there's, you know, some stuff with phages, you know, people are looking at. No formal programs, but there are cases that have been treated with various phages. There's case series, things like that. And there's a few companies out there trying to engineer phages. So I don't know. And then there's just regular hypertonic saline. Doreen are doing a trial for mild MAC where you just give them hypertonic saline to see if that is enough, and maybe that's enough. So I don't know what else is out there. Doreen, do you remember?
Now you hit. I mean, gallium was out there at one point,
True.
right?
Yeah. Yeah.
I'm not sure how it was given. Was it inhaled? But yeah, no, I mean, again, going back to the basics, looking at why your patient is getting infected, vigorous airway clearance, modifying any of the areas of immunocompromised state they have, all of those types of things. Maybe they need IVIG, and that'll take care of their MAC and their exacerbations. And then, yeah, I think we're particularly interested in the phages, and we've started a mycobacteriophage program here, and I know National Jewish now has, or they started theirs first, and we're following them mostly for M. abscessus, but there are matches now for MAC and other NTM species. So we are excited to see, and I'm hoping industry gets interested. There will be the first FAJ conference this year in Washington, D.C. So it's starting to take on a life of its own in the Mycobacteria area.
Yeah, and I just add there are a couple other TB compounds out there that are crossing over to in development that are crossing over to NTM as well. So I think there'll be more antibiotic options out there.
Well, we clearly need new antibiotics. I also think we need new regimens. I think of the TB model, these very long durations. We really would be nice if we could have shorter durations of therapy.
Yeah, absolutely. The other thing I was going to say, there's even some like novel, like biofilm busters out there that are being looked at. Yeah. Just break up the biofilm in the airway and expose these bugs to another antimicrobial, or even in some cases, those biofilm drugs are antimicrobial themselves. So I think there's several other strategies out there.
Yeah, in the CF space, the CFTR modulators have reduced bacterial burden by a lot. So that whereas maybe up to 15% of our patients were growing mycobacteria, we're not seeing numbers like that anymore. So you think of these other adjunctive therapies. So I'm going to exercise my right to go over. We have a new drug that was just approved. Do you see a role for this in MAC lung disease? Talking about brensocatib?
Oh, yeah, I thought you were talking about GLP-1 agonists for some reason. They seem to be good for everything. Yeah, I don't know. I mean, it's an anti-inflammatory compound, and I think it will be good for those patients who have underlying bronchiectasis. I don't know that it's going to affect the NTM one way or the other. We have to do those studies, I think, to find out. I don't think it should be detrimental to people with NTM. I have a hard, from an MOA standpoint, I don't see why it would harm people's ability to control their MAC. And then on the flip side, would it help them get rid of MAC? I don't know. I don't really see that either. But I see that it may just make them less congested and cough less and get less flares due to other things. But I don't know. We got to do the data.
All right. Well, thank you, Doreen. Thank you, Kevin. I'm going to close it down and say to the audience, thank you for joining. We did get a few comments that I can just say, including one, Doreen, your father was somebody's attending when he was an intern in Staten Island. They apparently liked your father.
That's wonderful. Thank you.
To the audience, for more info, thank you for joining us. And for more information on NTM lung disease management and treatment, there is a Medscape CME symposium at ID Week. That's on October the 19th. That's in Atlanta, where there will be some experts who will present some cutting edge data and practical insights. So I hope this was helpful to you, and I thank you all for joining us.
Thank you.
Thanks, guys. That was fun. Cheers.